Hello, my name is Bob Gould. I am a professor and vice chair in the Department of Radiology and Biomedical Imaging at the University of California in San Francisco. And this talk is on breast and thyroid shielding during CT imaging. So we know there are a lot of ways to minimize CT dose. First and foremost is careful protocol selection. No substitute for that. We also know that the machines are capable of reducing the dose for a given procedure by using tube current modulation, which can reduce the dose substantially depending on the body part. We know more recently that some iterative reconstruction algorithms have reduced dose substantially, 20–30%, even more in some cases. There also is a movement to do more adjusting of the KV based on patient size. And the last one possibility, this is not an exclusive list, there may be other ways of minimizing dose as well, but is the use of bismuth shielding. So bismuth is a heavy metal. And the way this works is it is placed over the organ that you're trying to protect. And it has been shown, for example, at the lens of the eye or the female breast to reduce dose by 30% or more. So it can do a substantial dose reduction. Certainly can be used in the thyroid as well as the eye and the breast. So as I said, bismuth is a heavy metal, has a Z of 83, approximately 1 millimeter thick in a flexible plastic is how this comes. The idea is that it reduces the beam intensity as the beam enters the patient. It does certainly do that, but the dose reduction is greatest near the shield. In other words, the dose reduction that occurs is not consistent or uniform throughout the slice, but is greatest near the shield. It does result in a noise increase, a statistical increase in the noise, which is also greatest near the shield, and it also distorts the CT number near the shield. And you can see that in this phantom head where the shield is placed right on the object, and you see that white elevated CT numbers there. The problem, or one of the drawbacks to bismuth shielding, is it does also attenuate X-rays exiting the patient. So this is a significant drawback because these exit X-rays bear information. That's the beam that's going to be used to form the image. And you really don't want to be attenuating those. So attenuating beams on the entrance surface, X-rays on the entrance surface, that can reduce dose. Eliminating them on the exit surface doesn't have any effect on dose, but has an effect on image quality. So this is some work done on a phantom at Mayo Clinic, Cynthia McCullough and her graduate students. And you see the influence of putting the bismuth shield at different distances from the surface of the patient. There's normally about a 2 centimeter lucent pad that on which the bismuth is attached. This resulted in about a 30% reduction in the dose, and depending on where the shield is placed, you see that the artifacts produced when it's right in contact are very much reduced. Usually about 2 centimeters is the distance that is used clinically. So these have to be used very carefully. In other words, some training is required, not extensive training, not difficult training, but definitely the technologist needs to be involved, needs to be trained on how to use these. So the bismuth shields are placed on the patient after the scout image is acquired. So you don't want the auto-MA compensating for the bismuth. And typically the auto-MA, this automatic variation in tube current, is based on the scout image. So you don't want these in the scout image at all. And furthermore, there are some scanners that have on-the-fly adjustment of the current. And the extent at which it does that could also mean that the bismuth should not be used. So, as I indicated, these are offset about 2 centimeters from the patient's surface using these foam pads. And you also have to make sure that you position the shield so that the curvature is parallel to the skin surface, because they can produce streaks, normally do produce streaks, and you want these streaks to not be within the anatomy. And again, this offset of 2 centimeters is critical to prevent that from happening. So here are some clinical examples, different size women, and you see that the image quality is really very good. There's a lot of discussion about, well, these affect the noise, they affect the CT numbers in particular. All that is true, but this occurs close to the shield. So in fact, from a clinical standpoint, and there have been several papers on this, there really has never been shown any deleterious effect of placing the bismuth shields, with the exception if they're incorrectly placed, so that they're streaking or some other artifact, again, if they were placed right on the surface of the patient, that could be a problem. The other aspect of this, particularly in women's breast, is if there is an effect, again, the effects are greatest near the shield, it's really outside of the chest wall. So in the breasts themselves primarily, not within the anatomy inside of the rib cage. So it really produces or doesn't really affect image quality, the clinical image quality. So one of the challenges is the tube current modulation, and Siemens and Philips adjust the tube current based at first on the scout view, but they do have some online feedback. And this feedback mechanism, as I indicated, could result in increasing the X-ray beam as it's passing through the shield and therefore defeating the purpose of the shield. There's no good paper that has demonstrated one way or the other. Generally, the feedback is a little bit softer than the adjustments made based on the scout view. I'm not sure soft is the correct term, but there's less manipulation of the beam current based on the feedback than there is on the scout view or topogram. So the pros and cons of bismuth shielding. The pros are that it's widely available, they're inexpensive, easy to use, but again, I state that the technologist needs to be carefully trained. They are quite effective, 30% or so reduction when used correctly, and it produces a very clinically acceptable image. But the cons are that it attenuates the exit beam, which, as I indicated, is not desirable. It does increase the noise a little bit. It can cause artifacts if not positioned correctly, and it may not be appropriate for use on all scanners. So it has to be thought out when and if to use bismuth shields. Certainly if you're trying to do any quantitative work, that is measurement of CT numbers, you don't want to use bismuth shields. So what are the alternatives? Well, one is I could just reduce the MAS. This increases the image noise throughout the image and deteriorates the image quality. So if you really selected your protocol correctly, and if you have set up your auto-MA correctly, I don't really feel this is an option, because now you have an image of that's been deteriorated because of the reduced MAS, so a sub-quality image. There also is what's called organ-based tube current modulation. This is offered on Siemens scanners. Probably some of the other scanner manufacturers will follow suit. And here the tube current is reduced in an arc of 120 degrees. This would be above, for example, the breast. So you decrease the output of the tube in that 120 degrees, but you increase the output of the tube in the lower 240 degrees of arc, so that the MAS per rotation is unchanged. That means the noise level within the image is not going to be decreased. So this has no effect on CT numbers. So on paper, this would be an ideal method of reducing breast dose or even thyroid dose. However, in practice, the constraint of 120 degrees is a serious one. So while it may work for some patients, for example, the one on shown on the left-hand side, as you look at the slide, that would be a good match between where the breasts are. But if you look at the right side, you see that the breasts would, in fact, a significant fraction of the breast would be subject to even higher dose, because remember that lower 240 degrees, the output of the tube is being increased. So it's very inflexible and would only work on a subpopulation of patients. Now we also know that we use effective dose, which is a weighted summation of organ doses expressing the same cancer risk from a non-uniform dose as that of an equivalent uniform whole body dose. So we know from other talks, effective dose is widely used and widely reported for CT procedures. The way you determine effective dose is you have to figure out what the dose is to critical organs, sensitive organs. You then have a weighting factor that you multiply those doses by, and you simply add up those organ doses, are then summed together. The weighted organ doses are summed together to get the effective dose. So here's the table. This is the 2006 ICRP numbers of particular organs and their weighting factors. So I want to look at this carefully. And here's the breast with a weighting factor of 0.12. In fact, this was a change between earlier ICRP numbers and the 2006. This was the biggest change. It went from a weighting factor, the breast went from a weighting factor of 0.05 to 0.12. A very significant increase. So that is one of the reasons why you would like to reduce the dose to the breast, because it does have a significant weighting factor. Only the problem is, here's the lung. It has the same weighting factor. So at least for tube current modulation, organ-based, that says that if I go in the lower 240 and jack up the dose and reduce it to the breast, I'm trading off breast dose for lung dose, and the lung has the same weighting factor. So I'm not sure how much sense, at least in terms of breasts, this organ-based tube current modulation, how effective that would be. It doesn't make sense to me to give the lung greater dose to spare the breast if they both have the same weighting factor, which the current ICRP report says they do. So the pros and cons of organ-based are, the pros are that the image quality is really maintained. There's no change in the noise, no change in the CT number, there's no introduced artifacts, and there's no attenuation of the exit beam. Also, it's quick application. You have no positioning of the shield. You don't have to enter the room after you've scouted. But the cons are that it has limited availability, really Siemens only at this point, although, as I say, that may change. And it's unclear to me that the trade-off for breast dose for lung dose makes a lot of sense. And furthermore, the effectiveness is a function of breast position and breast size. That is, it is not the same for all individuals. So there are pros and cons of both techniques. However, the AAPM has come out, the AAPM, the American Association of Physicists in Medicine, has come out with a policy statement on bismuth shields, which acknowledges that bismuth shields are easy to use and can reduce dose. But it does also state there are disadvantages. It states that other techniques exist that can provide the same level of anterior dose reduction. That's true. However, if we're giving it to the lung, it doesn't, as I keep repeating, make a lot of sense to me. So the AAPM recommends that these alternatives to bismuth shielding be carefully considered and implemented when possible. So they're not a little wishy-washy on this, frankly, and it's more acknowledgement that bismuth shields have some significant limitations, which I fully agree. But it also is true that they're effective. So, the summary, bismuth shields reduce the dose to superficial organs, including the lens of the eye, the thyroid, and the breast by 30% or even more. So, in other words, they work. That's the bottom line. They work. But training of technologists is important. They're inexpensive, easily available, easily implemented, but they're not perfect. And the major drawback is this attenuation of the exit beam. So I agree with the AAPM statement that you need to think about this carefully and make sure that if you implement this, you do so in a thoughtful way. Thank you.